Hello friends, welcome to Health, Music and Fitness channel. Welcome to ECG Vlog number 10. Thank you for visiting the channel and thank you for liking the videos and commenting on the videos. Every other day we produce videos and upload them, and they pertain to different topics related to health, music, fitness and technology also. I am Dr. Robert James, working as Associate Professor in Medicine. I am also a Fellow in Clinical Cardiology and Clinical Echocardiography. I am a writer, musician. My albums have been on the ballot for Grammy nominations. And I am also a marathoner, interested in sports, medicine and sports nutrition. And I am sure visiting this site will be of help to you. If you like our videos, please hit a like and also press the bell notification icon, and if you haven't subscribed yet, please do subscribe to our channel right now. And now we'll start with first we'll just go through the changes and then we'll discuss the ECG. Look at the rate rhythm axis after you have seen the calibration. So we'll start with the interpretation of the ECG. If you see the calibration is normal, is 10 small squares height and the plateau is flat, so that's a normal calibration. Then you look at the P waves are of normal shape and duration, so it's coming from the SA node and it's a normal sinus rhythm. So this is the P wave, it is a sinus rhythm. Then you have to see the axis and the heart rate. So heart rate I had told you is 1500 divided by number of small squares between two RR intervals. So that is coming to around 1500 divided by 12, 125. So the heart rate is 125 beats per minute, or you can divide 300 divided by number of big squares between two RR intervals, and that will give you the heart rate. Then you look at the axis. So for axis I had told you have to see in lead 1 and lead AVF. Lead 1 is sort of isoelectric, which means R roughly equals to S. And I had told you if one lead is isoelectric, the axis is lying perpendicular to that lead. Lead 1 is isoelectric, lead 1 is lying at 0 degree and AVF is lying perpendicular to it. So the axis is plus 90. It's a slight right axis deviation, is going towards the right axis side. At this point you should think of the causes of right axis deviation. In the MIs we are discussing myocardial infarctions, so obviously we are discussing myocardial infarction in this. So if the lateral wall, the left ventricle is gone because of infarction, the positivity of the left leads is decreased, so you can mark at the negative side of 0 degree, that is 180 degree. And I told you current can travel only in one direction, it can't travel in both the directions. So if lead 1 is becoming negative, lead AVF will become positive. So plot lead AVF at plus 90 degree. So that makes it a right axis deviation. So if there is a right axis deviation from myocardial infarction point of view, you should think of lateral wall MI or anterior MI. If there is an inferior wall MI, it will cause left axis deviation. Of course, if there are arrhythmias, they will alter the axis too. Now we'll look for anterior wall MI. So look in lead V1 to V6. There is marked ST elevation, and this is hyperacute state of MI. MI is occurring right now and you have to thrombolize the patient. The Q waves haven't formed yet, and thrombolysis will help this patient if there is no contraindication to thrombolytic therapy. So after some times the ST will start coming down, the T will invert and the Q wave will form, and then probably thrombolysis might not help. The R waves are still there. So this is anterior wall MI. Then you look in inferior leads, lead 2, lead 3, lead AVF. I had told you in MI there is a subtle change which many people miss. There is merging of ST ending and the ascending limb of T wave. So out here you can see there is that merging is there. Slight ST elevation is there. You should pick up this ST elevation. Most will just ignore it, but if you do echocardiogram on this patient, he will have inferior wall, posterior wall hypokinesia and the lateral anterior wall also. So it's a massive MI occurring. It's inferior wall MI as well as anterior wall MI. Also, if in lead 2 you have noted something, look in lead 3, lead AVF. In AVF also the same feature is there. There is merging of ST into the proximal limb of the T wave and it looks slightly elevated from the isoelectric point. And we have not covered the blocks yet, AV blocks, but you should remember there are 3 types of AV blocks. First degree, second degree, it is a further 2 types, and there is a complete heart block. In first degree heart block, the PR interval is more than 1 big square, 0.2 seconds. And in this ECG, you are seeing that there is a first degree AV block. The PR interval is prolonged. It's more than 5 small squares, 0.2 seconds. And in lead 1, you can see there is a ventricular ectopic. It's a broad QRS complex, and that's a VPC. And if you thrombolize this patient, sometimes you will get runs of VPCs, and they are called reperfusion arrhythmias. And but you should be very cautious. If 4 or 5 VPCs occur in a row, it can give rise to ventricular tachycardia, and that can be very fatal. So your equipment should be ready, the defibrillator should be ready, the anti-arrhythmogenic drugs, Cordarone and other drugs, they should be ready to handle the cardiac emergency. So this is all in this ECG, and thank you for watching, and please do subscribe, like, comment and share the video with your friends. Thank you.